Good afternoon, everyone. On behalf of the Agora Organized Committee and Eleana, we warmly welcome you to this thematic panel on young patients and family support. My name is Artemis Margariti. I'm health visitor and I serve as a general secretary of Eleana. I'm very pleased to be co-chairing this important session alongside Mahi Salamaliki, special secretary of Eleana. Today's panel focuses on the unique challenges faced by young patients and the crucial role families and caregivers play in their journey. We will also touch upon important topics such as reproductive health and living with RMDs throughout all stages of life. We will begin our session with Dr. Rubini Smerla, a pediatric rheumatologist and head of the Pediatric Rheumatology Clinic at Euroclinic for Children. Unfortunately, Dr. Smerla couldn't be here with us today, but she kindly prepared a pre-recorded video to share her insights. Let's go.
I would like to thank the organizing meeting for this kind invitation to participate in this meeting and talk about growing up with a rheumatic disease, challenges faced by children and young adults with juvenile arthritis. What is idiopathic arthritis? Idiopathic arthritis is a chronic inflammatory condition that affects joints. It causes pain, swelling, and stiffness. It affects children under 16 years old and has varying types. This type is called juvenile idiopathic arthritis. It may also affect other organs. For example, we may have eye involvement. What it means living with a rheumatic disease? Of course, it doesn't necessarily have to live with a limited lifestyle. We know that all the members of a family are affected by a child's diagnosis, and they all make effort to maintain as normal as they can. And it is possible. If they have correct management, JIA may not have to interfere with child's or teenagers' activities. What is very important for this? Exercise. Why? Because exercise reduces symptoms, prevents joint stiffness, improves joint flexibility, reduce pain, swelling, and maintain strong and healthy bones and, of course, cartilage tissue. Besides, exercise improves joint alignment and, in general, improves overall fitness. What else? Diet and weight management. Children and young adults with juvenile idiopathic arthritis have to take care about that. Variety of food supplies the body with the nutrients it needs. It helps stay away when staying away from high fat, sugar, processed foods may reduce inflammation. And of course, children with JIA have to control their weight by maintaining a healthy weight, reduce strain placed on joint, knees, and hips. Sometimes a nutritionist may be involved if it's necessary, of course. How can we help a child cope with rheumatic disease? Chronic pain and fatigue may leave a child feel depressed and less able to cope with the pain. Joining a group support can often be helpful, and being a part of correct pain management involves better treatment, better results. Getting plenty of rest also preserve energy, includes adequate sleep and relaxation. And let's see in details. Adequate sleep, what does it mean? 8 to 10 hours helps to maintain energy level, to restore spirit, and helps joint to rest. Besides, relaxation minimize the stress symptom and help muscles to get relaxed. Life with arthritis and rheumatic diseases is not so easy for the young children, for the young adult, for teenagers, and they face a lot of difficulties. For example, explaining their condition to their friends, what happens, what is their disease. And the other problem is navigating through the school system and many others that everybody faces personally, of course, individually. What can we do? How can we help? We can have a relationship with the child, with adolescents, care team to be part of this effort, to keep through medical records, to get the child school involved so the child does not feel alone or ashamed sometimes. And of course, stay educated. It is very important to stay educated because you learn about the disease, the way you have to face it, the therapies, etc. So you are not so afraid of it. In a few words, we would say that awareness and prevention are very important. And what does it mean? Early contact to a doctor with the first symptoms. Medicine. Nowadays, we have new therapies, not only the classical DMARDs we had in the past, and now we have biologic JAK inhibitors, CAR T cells. Precise medicine is very interesting, of course. Individualized medicine. The field of artificial intelligence promises a lot in all the fields. And don't forget the vaccinations. It is a powerful tool to reduce the burden of infectious diseases. Of course, vaccinations have to be adjusted. We will not talk in details now about live vaccines, etc. And in general, they have to take care of the lifestyle in general, as we talked in the previous films. We talked about exercise, about weight control, about the food. Many countries have a day of awareness of each disease, of autoimmune diseases, juvenile arthritis, and other diseases. It is a crucial initiative and aims at transforming the lives of these children. So, through increased awareness, we can help more. Don't forget education, support, advocacy aspires to create a world where individuals with rheumatic diseases lead healthier and more fulfilling lives. Thank you for your attention.
Maxim. And now, let's hear from a patient's perspective. We are pleasant to welcome our next speaker, Theonosia Apostolou, General Secretary of the Cyprus Rheumatology Association and coordinator of the Parents and Children's Group. She will talk us about the personal experience of growing up with the rheumatic disease and how it has suffered has everyday life.
Hello to everyone. Good afternoon to everyone. I am Theognosia from Cyprus, and I am a person living with rheumatic disease the last 25 years, and also a mother of a 17-year-old teenager who has lived with a rheumatic condition since early childhood. I'd like to ask you to close your eyes, imagine a child running, laughing, and playing in the schoolyard, and suddenly stopping and start crying and feeling pain, but does not understand where is the pain, and you cannot see the pain. It's a pain you cannot see, but it's always there, and the child is crying and stop playing, and start crying. This is the daily reality for many children living with rheumatic diseases. Juvenile idiopathic arthritis is the most common chronic rheumatic disease in children. Europe rates for GIA range from 2 to 20 new cases per 100,000 children per year, although this can vary by country. And in Cyprus, a pediatric rheumatology clinic monitors around 230 cases across the spectrum of pediatric rheumatic diseases. And juvenile arthritis is not just a medical condition, it's a way of life that touches their childhoods and adolescence. Although my daughter has not diagnosed with juvenile arthritis, but with Mediterranean fever, most of the symptoms and the way of life is the same. The journey was not easy for me, but it taught me a lot. From sleepless nights in the first months when my baby cried in pain and burned with fever, endless visits to doctor without clear answers. Every 25 days, the symptoms returned, yet we remained in the unknown. At that time, of course, Cyprus has not structured health system, not specialized services, although since now we do have only one pediatric rheumatology in Cyprus. Eventually, then, through my own experience as a patient and my determination as a mother, I began to suspect a rheumatic disease. At around age 3, we finally reached the only pediatric rheumatology available in Cyprus. It was a doctor. She was a Cypriot doctor which was lived in Sweden and visited Cyprus twice a year. Okay, it's okay. Thank God, my daughter adapted relatively well to living with her condition, having faced medical tests and doctor visits and treatment from infancy. But not all children are as fortunate. On average, children with GIA and other rheumatic diseases miss about 1 to 3 school days every 2 months, and around 1 to 10 had clinical depression. Growing up with GIA and any other rheumatic disease is far more than managing a physical condition. It is a complex journey with challenging in 3 main areas. Physical and medical challenges, which is chronic pain and fatigue, frequent medical appointments, and long-term treatment are a daily reality. Side effects such as delayed growth or reduced bone density can further impact their quality of life. School attendance, sport participation, and even simple play can be restricted, affecting their overall development. Psychosocial challenges, living with visible or invisible chronic illnesses can be isolating. Absences from school may lead to being behind academically, but the most important is that feelings of being different can result in social exclusion and bullying and increase the depression. And the third area which I and my daughter are facing now is the transition to adulthood. Okay, moving from pediatric to adult healthcare is often stressful also for them and for us and for the parents, as the young people must take greater responsibility for managing their condition while also making important decisions about education, career, relationships, financial stability, independence, and all of these complexity are all together, and it's very stressful for them. Also for us as parents, this transition is very stressful, and the most greatest fear is the future. What will happen where we are no longer able to be there for our children? Who will take care of them, or will they take responsibility for their conditions? They will remember to take their medication, to attend their medical appointments, and in the worst cases and scenarios, what will become of our children where we are no longer alive? Managing juvenile arthritis and non-rheumatic diseases it's beyond the medical treatment. It's about ensuring that our children can continue to dream, learn, socialize, and plan their future. And this requires policies that protect the right to education, accessible rehabilitation, and mental health, and public awareness and campaigns that help the society understand and support their needs. Of course, the role of support networks is vital. Family, healthcare professionals, and patient organizations, education, which can help reduce stigma and build understanding. Advocacy is crucial for early diagnosis and access to innovative treatments and the development of support systems that enable children and young adults to live their lives. And of course, these children are not just patients. They're fighters. They fight every day for things we may take as granted, Mahi. And of course, their disease does not define them, but their dreams. And what about us? We are calling for action. We have a duty to stand beside them, to speak up for early diagnosis, to demand access to care and treatments, and to take sure no child loses their childhood because of a disease. Thank you, and let us work together so that children and young adults are not defined by their illness, but empowered by their dreams and their potentials. Thank you.
Thank you, Theognosia. Are there any questions from the audience?
We can take any questions, actually. I'm told there's no time for questions. Is there? Oh, okay.
Yep.
Thank you so much. That was a really beautiful presentation of some very difficult issues.
Thank you, Neil.
Making me feel quite emotional too. I just wanted to sort of thank you. As someone who went through something quite similar, aged 4, 5, 6, that period, you're right, children are fighters and can be very resilient. And I think handling the pain, and I myself had eye issues as well, you kind of, can do that. And I found one of the hardest things was other people, not myself. So whether that's your peers, disbelieving you because only old people get arthritis. So you are kind of indirectly being called a liar all the time, you know, and the stigma that goes with that's horrible. And also your parents, because parents can't hide your emotions 24 hours a day, right?
No.
And when
No.
you're so young and you look to your parents for solidity and they know everything, if they're okay, I'm okay, that's so tough. So I just wanted to thank you for your courage in sharing
Thank you.
today.
Thank you very much.
Let's continue with the topic of family and caregiver support. So let's continue with the topic of family and caregiver support and how families can effectively support young patients while also taking care of their own mental and emotional well-being. Our next speaker is Nadia Maliou, PhD candidate in anesthesiology and intensive care psychologist, president of PAE.
Well, let them
all of
read
them.
it.
Yes.
Just on, if we have the presentation, the slide up.
Yes,
they
yes,
can
let's
read
start.
it.
Let's continue.
And let's not lose precious time from the audience. So, hi, I'm Nadia Maliou. One thing you need to know about me, I am involved with pain patients like almost every day of my life. I am a pain patient, but I do support pain patients. So my presentation here is going to be on the family and caregiver support. So I struggled with this presentation exactly for the same reason as Neil just mentioned and got emotional about, not because I was at a really young age a patient myself, but because I do know from the lived experience, but also from the professional side, how difficult it is for the family to navigate and cope with all this that Theognosia really shared with us. And she has a unique perspective. And if I ask, like by show of hands, if you want to share, who do we have present here being a supporter, a caregiver in the room, a caregiver of patients living with RMDs? And I know my daughter is over there, so she must, yeah. Hi, Eva. So a caregiver and a patient living with an RMD or any other disease. So I think the rest of you or some of you. So we do have people with lived experiences of both perspective. So I've struggled with that. So I'm really sorry for any difficulty on my side also. So the presentation is going to go. I'm trying. To talk about a little bit about the burden of the chronic pain and the RMDs. And I'm going to talk a little bit about the psychosocial support and how that includes family and caregivers. I'm going to talk about the role, and we've already talked about it through Theognosia's mentions and Neil's mentions. And I'm going to give you a little perspective on the impact of caregiving per se, and how can we maintain the well-being. And then I'm going to give you the key takeaway messages. Just briefly mentioning, ladies, hello, just briefly mentioning the impact. And I don't want to stay longer because you already know the impact. It's huge. Only in the European region, it's 120 million patients with a kind of an RMD. So huge impact of RMDs and a huge impact of pain also. So that means that patients actually live with a lot of burden, and this is out of the SIP Book of Evidence, the Societal Impact of Pain Book of Evidence, which actually focuses on patients' lived experience. But what do I want to bring you here is that when we have patients living in that kind of situations, normally we do have people living around them, and I don't want to just focus and say families, because families may be any type of families, spouses, partners, friends, like extended families, whichever type of family you want to imagine, that's the caregiving environment, and that's who this is about today. So, when we talk about psychosocial support, which everyone agrees upon, and we know that's medication that works, that's yoga, Pilates, exercise, non-pharmacological, we all know, talk about it, and then someone says, and of course, psychosocial support, and of course, CBT, therapy, it works, of course, and then someone says, yes, yes, and social support also, communities, we need to reach out to everyone, yes. Easily said, not so easily done. And the first line of support for everyone is the person that lives with you, that goes to bed with you, that stays in your house, that sees you every morning when you get up and you're like mumbling stuff, or you don't feel like talking, or you want to talk like way too much because you're too tired, too much in pain, or they are too tired. Because let's not forget, when you live in a house, you are there, the patient, but they are also there. So this is not only about you, it's about you, the patient, but about them also. And there are too many realities in the context of people living in a context of an RMD being present. So psychosocial means you and the others. So, and what is the caregiver's role? It's physical, when they give you a hand, when they take and they like help you get up of a chair, when you are using a mobility device or whatever that entails. It's emotional, psychological. They're not therapists, but like so many times you vent on them. You're like they are the most powerful fans of you. Like my daughter is here to like applaud and support me. Like your PAs come along on the trips and say, hey, you're doing really well. They are the medication and treatment management. So when you are not able to do it, the adherence, have you taken your pills? Theognosia said, I'm there to support. She has her own. She has to support also her daughter. And the advocacy and communication, oh, come on. How many times have a loved one has come along with you at the doctor's office, and the doctor was saying, oh, you have to do this and this and this, and then the loved one says, hey, come on, speak slowly. She's tired. She's fatigued. Speak slowly. She doesn't understand. The advocacy is there with you when the loved one is there with you. And the practical support, going to the supermarket, just lifting a bag. And it's a matter of cultural factors. When we are, for example, the Mediterranean people will totally understand when we say it's a duty for a Greek family or maybe a Cyprus family, it's a duty for the woman to support. Even though she's like yourself, Theognosia, or myself, if you're a woman in Greece and maybe you are a patient, you should absolutely support if you also have another patient in the family. You should run to hospitals. You should do everything because you're a woman. That's a cultural thing. Sometimes in other countries it may never happen, but in Greece you have to do it. So what is there to say about roles and gender-biased expectations and stereotypes when it comes to caregiving? And then we have types of caregivers, and I'm not going to bother you with too many details, but I have to say we have the professional ones, the ones that can actually give you an injection, provide you medication, can actually do things for you in a very informed way, in a very professional way. And we do have the other ones that don't know how to do this, but they are there for you daily. And do we have people that can do both? Yes. Do we have many, many other types of caregiving? Yes. And should I go into details here? No. I just want you to know that your loved one is probably an informal caregiver. Can they become a professional one? I don't know. Yes, maybe. It's irrelevant. We're talking about families here. They have started out as informal caregivers. Should they become something else? It's a choice. And a little bit of scientific data. They've asked focus groups of patients and caregivers, how do you perceive the whole idea of being with a patient in a home, having an RMD, and what are the most important things happening? And they discussed in groups, separate groups, they both discussed and gave focus on the loss of purchasing power, because when you have an RMD, both groups, even the caregiver, have to like limit the working hours so they can help out. So loss of purchasing power, work problems, social isolation for both groups, even the caregivers, emotional stress, and physical impact on caregivers. That came out from the group of the patients. So they were aware how that impacts the caregiver. Moving on to another survey, experiences of caregiving and quality of healthcare among caregivers. So they said they discussed in focus groups again, and they discussed what's happening when we live with a patient having a chronic illness. And they said, so 95% of patients, they stay on at home and they depend on us, on the caregivers, which is actually a reality. Yes? Is it? I think yes. And being a caregiver implies a high workload. So do we have to do enough for us? Yes. So if we live with a patient with an RMD, we even have to do more. So high workloads. They highlighted the negative impact of caregiving on their physical, mental, and emotional health, again. And there is not enough care for either the patients or themselves from the healthcare systems. That we already know. And this is a very nice survey. I put it here for everyone. And the outcome of the survey, I don't want to say too many details, but they looked into the caregiver burden in comparison to the self-efficacy of the patient. And the outcome was that the low self-efficacy of a patient impacts the burden of the caregiver. So if we have a patient with low self-efficacy, so we have a very burdened caregiver. So what does it tell us? If we empower a patient to take more on themselves, to feel empowered and take, even emotionally, then we can have less burden for the caregiver and vice versa. Yeah? So it's a context that everybody is impacted by everybody. And then this has to be really clear for every one of us. So it kind of ends up here. If you live with a person, and as like already said in the room, if we live with a person or we are a person, either caring for someone or we are the patients living with someone that cares for us, we can end up here. The needs of the caregivers are very much similar to the ones of the patients. The caregivers actually need feeling of community, access to informal support, grief acceptance themselves, monitoring and guidance, assistance for the care services, and access to practical information without being overwhelmed. They kind of end up patients themselves. And this is quite, I don't want to say shocking, but they end up like patients themselves. And it's quite important to be aware, everyone to be aware of that. If you are caring for someone, you may end up being a patient yourself. So how do we maintain the well-being? Kind of using the same approaches as a patient. Self-care, stress management, social support, professional help, education, and caregiving skills training. Does this sound like the things we say to the patients? Yeah. Yeah? Yeah. Because it kind of is. Yeah? If we were to be talking about ourselves, like self-management, it would be like that. So it kind of is the same to maintain the well-being of caregivers. Doesn't matter if it's for younger people or older people, it kind of is the same if it's RMDs or any other type of disease, but it ends up to this. Yeah? This way we can prevent burnout, improve quality of life for the caregivers also, and enhance quality of care for the patients. And we can all use tools. We can even work together. So we can even be here present, all of us, caring for others, being cared for, doesn't matter. We can take each hat anytime, doesn't really matter. We can switch places and we can use the same toolkits and we can even imagine ourselves being in both perspectives. Yes? And I'm kind of rushing through and I'm really aware of the time because I want to give you this example. I mean, this lady, I'm going to name her Katerina, and her husband, I'm going to name Stamatis, not real names. Okay, I talked to her 2 years ago over the phone. She was a case from the helpline of Eleana. So she called me 2 years ago saying that my husband just got diagnosed with AXPA. We are at a loss, please help me. We had an hour and a half phone call, and I kind of tried to help her over the phone. She called me 4 days ago. 4 days ago. And she said, oh, I'm desperate. I really need help. And she came yesterday after my nap. And while you were seeing the amazing Acropolis Museum, she came downstairs. We had a coffee. She's the caregiver. And we had a really nice discussion about how frustrated, how the burden, the denial of Kyriakos, the emotional stress, the whole situation getting out of her control, and she was like at a mess. And I just want a brief comment from all of you nice people about these two questions. If you were in this situation, being the caregiver, just imagine, what steps would you take to support like both her, like herself, and the caregiver, the patient, Kyriakos, Stamatis, Kyriakos, yeah, and her. What would you say? What would you do for her? What if you were Katerina? What would you do? Or what would you advise her if you were me? What would you say to Katerina? Any ideas? Yeah?
Replace her for 2 hours.
Yeah?
I would advise to try looking for kind of professional support, at least someone who can replace her for a couple of hours so that she can spend the time outside somewhere far and away from her partner.
Yeah. Yeah. And what about her husband, who is like denying one, is not adhering to the medication? He's like not really up to doing anything, or resigned from everything. Yeah, Andre?
Yes, first I would go and tell them that they need to, of course, to see a professional. But on the other hand, if he's on deny, it means that he doesn't want to speak to any professional. So I will suggest them to go to a patient organization to meet people that they are suffering from the same disease, to discuss with, for the patient to discuss with other patients, and for her to look after herself, to make a step back and leave him for little time alone. Because sometimes we as patients, we need our time to digest what is happening to us. Not all the time, we don't need all the time somebody to tell us that we are sick or something, that we have something. And we need also our time to digest all of this and to accept what is happening to us. Because I am also a caregiver, not only patient, that's why I am telling this. And as a caregiver, I need my time also.
So
I-
thank you.
I need to
Yeah.
I need to have my time to meet my friends, to talk my friends, to do my hobbies. I'm not a person that I am living only to be a caregiver or a patient.
Yeah. So, yes, Boriana?
May I add something? If the person, in your case, it's an adult, it's not a child. When it's adult, you can explain that he should take his medications or whatever it's needed. But if he doesn't accept, it's his responsibility. You are not a parent. If it was a child, it's a little bit different. It is the same with elder parents, for example. If they don't understand that they have to go to the doctor or to take their pills, it's their responsibility. It's not yours because they are over 18, so they can take responsibility for their for the things that they do and their decisions. So you can explain, but on the other hand, you are a human also.
Excellent. All of your reflections and answers are excellent. And I do appreciate, because these are all the answers I gave to Katerina, and then some, because because I also suggested suggested more information because they lacked knowledge. They don't know yet some information, some useful tips, some they don't even have routines set for the RMD and for themselves. So my key takeaway messages for today's presentation is that we know that we do have in our hands a very prevalent situation. So we do have patients suffering, and these patients, we need support. And we have among here some of us have our support with us, and caregivers provide almost anything for us in their daily lives. And it has a major impact on their mental health, on their well-being, on their social life. And this high burden, it kind of links and taps into our burden. So we are interconnected. And this is very crucial for us to understand it. And if they are well taken care of, our supporters, they can be their burnout can be prevented. Their lives can be improved, and it actually all of that can enhance our outcomes too. So we are in this, as Theognosia said, we are in this together. Yes. So a strong support network for all of us in our communities is quite needed, and supporting them is quite crucial with whatever we have at hand in terms of knowledge. I personally believe we need more research and more information about what's happening with the caregivers, for the families with younger children, for the families with adults, for the families with more comorbidities, for the families with specific types of RMDs. But that's another discussion. And supporting caregivers is quite essential for sustainable, high-quality care in RMDs in general and chronic pain. So I hope you can take away this and discuss it in your organizations about having more activities for the caregivers too. So thank you. This is a survey, finally, that PA Pain Alliance is doing. You can scan and take part in the survey as patients living with chronic pain. The theme of the survey is chronic pain, mental health, and self-management. So thank you. If you want to do the survey, please scan and follow your language. It's in several EU languages. Thank you. Do we have any questions, comments, or anything regarding
I don't think we have time. I'm sorry. We have to move on. We have?
I'm so sorry.
Okay. Okay, if we have,
We
that's
have
fine.
time, she says. No questions?
close this session, we are here from Dr. Chrysanthi Sardeli. She will address the topic fertility pregnancy with rheumatic disease, a subject that's vital importance for women at all ages living with rheumatic autoimmune disease. At the same time, is the essential that man, familiars, and the wider community are also informed and sensitive. Understanding these issues help create tomorrow a supportive environment for a woman, negative, sex, personal, and complex challenge.
Hello again. Thank you again for inviting me and having me over here. I have a suggestion for Stamatis. Where is Nadia? Did she leave? Nadia, have you discussed with Stamatis self-termination? That was a joke. Sometimes we need to accept that patients, Stamatis from your case, maybe people need to decide for themselves. They do nothing. So make a joke sometimes. I'm not always joking. Can I have my fantastic presentation? Yes, thank you. So fertility, pregnancy, and RMDs. No conflicts of interest here, except from a 25-year experience in obstetrics and gynecology. As we said earlier today, autoimmune diseases are very complex, heterogeneous in nature, and they occur many times in ages where fertility and pregnancy or lactation are of great social and clinical importance. So it is very important that we know what to do, especially in these years when we have underpopulating Europe. Most of you are from Europe, I can see. We have problems with birth rates. They are falling. So good news. Good news are that fertility is typically normal in women with RMDs that have not been treated with cyclophosphamide. And the same is also true for men. Cyclophosphamide, it's a medication that is cytostatic. It's controlling disease. It's an excellent medication for many categories of patients with RMDs, but it's very, very, as we call it, gonadotoxic. So for women, we have some instruments to counteract these effects. We can use hormonal co-therapy during the course of cyclophosphamide treatments in order to reduce risk of ovarian insufficiency. But in men, besides offering cryopreservation of sperm, there is nothing we can do. We don't have any medications to counteract these gonadotoxic effects. So what is very important when you have to do with patients with RMDs is that you need to counsel them on fertility when they are in the reproductive range of ages. We also need to discuss contraception with these patients because, as I will go on saying later, besides, we need to discuss pregnancy planning. Pregnancy goes better when at least the woman, but also the man, are in remission and they have a well-controlled clinical image. So, clinical situation. So it is very important to remember that we need to plan pregnancies. So we need to counsel people on very effective contraceptive uses. And this is from the American College of Rheumatology guideline. It was 5 years ago it came out. What you need to do is basically assess, for women at least, assess their antiphospholipid antigens. And then go and decide what to do. With the red, we have, for example, systemic lupus erythematosus, we need to avoid estrogen patches. The estrogens in transdermal form they predispose to thrombosis. So systemic lupus erythematosus, very high risk of thrombosis. We avoid this kind of route of administration. But in general, if you can see here, usually we have a problem with the SLE patients. The others might use, as I think it's here, most of the other patients, they can use IUDs with or without hormones. They can use pills, oral contraceptive pills, any kind. They can use also local therapies, long-term, like medroxyprogesterone and injections every 12 weeks, etc. So unless we have a present antiphospholipid antibody, or not antigen, antibody, excuse me, and a very active SLE, then we can use any kind of hormonal contraception. But of course, there are also the barrier methods, a diaphragm, a condom. Okay, fertility awareness-based methods are not very good. We have, after 1 year, 24% failure with timing of ovulation or withdrawal. And spermicide is even worse. Condoms fail 18% of the time. So, but these are also measures we can use kind of consistently instead of nothing. Oh, there is a no there. However, as I said earlier, the fertility is not impacted when you have RMDs. However, more and more people delay pregnancies. And of course, sometimes the disease itself might make us delay a pregnancy. So we might end up with fertility issues, and we might need to go for assisted reproductive technology. And then again comes the American College of Rheumatology guideline, and they kind of give us an algorithm here. It's quite good. We determine the disease activity for the RMD, and then we move forward. And unless we have moderate or severe disease activity where we defer resorting to assisted reproductive technologies, then we might go forward in all other possibilities. So having rheumatic musculoskeletal disease is not a no for assisted reproductive technologies. It's okay. Okay. They need me to be perfect. Thank you. Thank you very much. I need to move around. I'm getting bored. So it's, but of course, it's more complicated having to go through ART unless you use some medications prophylactic for thrombosis. And I need to tell you something here. Most people believe that taking an oral contraceptive pill is a no-no because of the increased risk for thrombosis. But actually, it's much more worse becoming pregnant, where the risk of thrombosis is concerned. Becoming pregnant increases 40 times your risk for thrombosis. Getting a contraceptive pill for women in an increased risk for thrombosis increases twice the risk for thrombosis. So it's much more difficult, even for non-sick women, healthy women, to become pregnant than to take a contraceptive pill. So no worries there. And having an RMD does not increase the risk. So it's also okay for assisted reproductive technology. And then we go on to the main theme. And what is the problem with pregnancy, besides having to breastfeed? But okay. So we have changes in the immune and endocrine signaling. And this we have because you need to think of the embryo, the fetus, or the baby inside the womb. You need to think of it like a transplanted organ. Half the baby is genetically related to the father, whomever the father is. And okay, don't laugh, but we have data from Europe that up to 15% of the children do not have the father we believe they have. That the fathers believe they have. And this is living outside sperm donation. where we know that the father is not, the social father is not the father. So guys, this is not my problem. This is truth. Only truth here. But okay, the data is a bit inconsistent. We have from 5% up to 15, 20%. But okay, I would say 15 to believe it. Okay, to become more believable. But in order for the baby to survive and the placenta to not be rejected and thus lose the pregnancy, our body is kind of self-immunomodulating. So the immunity goes down. The immune response goes down in a way, or differentiates. And this is also due to the sex hormones. Those of you who were there before in the workshop, we talked a lot about sex hormones. We have gradually increasing levels of estradiol, progesterone, and prolactin that, of course, remains very high after we give birth, especially if we breastfeed. So we have a difference in immune reaction that for some people is beneficial and in other people is not beneficial. For example, if you take healthy women, the immunosuppression they kind of have, or immunohypnosis, I would call it better, means that they have a very, very high risk of dying of viral diseases. So that's why we advocated for vaccination with against COVID for pregnant women. And we absolutely advocate now to be vaccinated for influenza virus when pregnant. It's extremely important. But for non-healthy women with RMDs, the same goes. But sometimes it's much better to become pregnant where your RMD is concerned. So in most cases, we have a down-regulation of the immune response, and we have an improvement of clinical picture. However, this only lasts until giving birth. And then, in many cases, you might have a flare-up. So, and actually, in order for the birth to start, the parturition to follow through, we have a very, very sharp estrogen progesterone withdrawal, and actually we have a pro-inflammatory state. Otherwise, the baby is not born. So everything fits together, but not the people with RMDs. So, however, we need always to speak about what happens in uncontrolled disease. When you have an uncontrolled systemic inflammatory disease, itself is associated with poor pregnancy outcomes. So we are not allowed to withdraw treatment. I have many, many people coming to my office because I'm perhaps the only one in Greece advising in use of medication during pregnancy, lactation, or before, when planning a pregnancy. And I have many women, especially psychiatric patients, they just stop the medications when they find out they become pregnant, and then they relapse. Other people do it too. No, never do that. In most cases, the medication is just safe and help you have a normal pregnancy. So what kind of risk of complications we have, we're going to discuss it later. But for people with RMDs, diagnosis, disease activity, and damage are very baseline situation is very important. And also the presence of these antibodies, anti-Rho SSA, anti-LA SSB, and anti-phospholipid antibodies. These kind of predict a negative outcome, or at least a complicated outcome. So from a lecture we had last week at the ENTIS, the European Network of Teratology Information Services, we had a session about biologicals in pregnancy. And this is the UK Teratology Information Services. Its head is an obstetrician gynecologist, Ken Hodgson. He gave me the slide, and I thank him. If you are a healthy person without need for biologicals, then you, especially inflammatory rheumatic diseases, you have a background risk of 2 to 3% to have an anatomical, to have a baby with an anatomical anomaly. It goes up to 3-4% if you are an RMD patient. If we are talking about stillbirth or intrauterine fetal death, it's 0.4% for healthy people it goes up to 1 to 2%. It's 5 to 8 times more. So preterm delivery, 7 to 8% without RMDs, 12 to 23% with RMDs. And all these situations, when you don't have a stillbirth, small for gestational aids also, more than doubling. All this preterm delivery, small for gestation, small birth weight, it means, small for gestational aids, it's the initials. It means very high morbidity. Babies need to go to the NICU, the neonatal ICU, and it's complicated for them and very complicated for the families. So if we can prevent all these things, then we want to prevent them. So we need very, very good pre-pregnancy control and not stopping the medications when they are needed. So we have, for rheumatoid arthritis, this pregnancy improves disease activity, slight improvement in disease activity for psoriatic arthritis, flares common in SLE, but okay, SLE is bad. We knew it. I wouldn't advise against having a baby when you have SLE, but you really need to think about it. So we need the mothers to survive, not only to bring a baby alive to term. So disease in Sjögren's syndrome might worsen and be complicated by pulmonary hypertension. Is not good for women to have pulmonary hypertension and carry a baby because they work for 2 or 3 people. So it is very difficult when you have women with pulmonary hypertension. In systemic sclerosis, usually the disease is stable, but if you already have a pulmonary hypertension, it might worsen. And then for the autoinflammatory diseases, there is nothing happens. It's irrelevant to become pregnant. So again, from the previous guideline, we need to plan. We need to plan the pregnancy. We need to plan the pregnancy so that we have a low disease activity and then move forward. But before moving forward, we need to also have time to change to medications that are pregnancy compatible and also keeping the disease under control. So this is, patients with RMDs are not allowed to become spontaneously pregnant. Sorry, freedom curtailed, but that's it. Because otherwise, they're not taking care of themselves and they are pressuring the healthcare systems. And then we go on by the same criteria as before. APLs present or not, SLE problem, and all these extra situations. So about my specialty, very, I saw that EULAR, you have also a guideline about medications in pregnancy and lactation. And I saw that I compared it with the American College of Rheumatology, the ones I have been using their pictures in this presentation. You have similar results as you categorize the medications, but your categorization is kind of wrong in the sense that you are overestimating risk. So you need to collaborate with us in the teratology information services, the people doing reproductive toxicology, because we have much more data, or at least we have a way to find the data, because there are a lot more medications that are allowed to be used than we, or your guidelines mention. But in general, of course, we avoid the use of known teratogens, like methotrexate, cyclophosphamide. I have more later. Remember that biologicals that we believed some time ago that because of their, there are big molecules with many kilodaltons. We believed that the placenta will not allow them to pass from the mother to the baby. However, nowadays we know that these medications do cross the placenta because the babies, as they developed, the first trimester is where the organs develop. There, these medications, biologicals, do not cross the placenta, so we are not having any teratogenesis. We don't have anatomical anomalies, but they do pass through from the mother to the baby during the second and third trimester, and this causes immunological modulation to the baby. So when they are born, especially their B cells are not working, so we need to change the vaccination plan, especially avoid it. It's contraindicated to vaccinate for BCG with live vaccines. So we need to cancel the women or the families that the mother used biologicals during pregnancy, the second and third trimester, that the pediatrician should know about it and change the vaccination plan. Biologicals stay in the baby's bodies for many months. They have a very long half-life. So at least 6 months we need to stop vaccinations, but also we need to take care of these babies, exposing them to antigens, virus, and etc., because it takes a lot of months for them to become fully immunologically competent. So this is something else we need to do. Counsel them. It's excreted, the biologicals are excreted in human milk, but in very minuscule concentrations. We don't care about that so much. So it's allowed to breastfeed. And I need to remind, because people with RMDs usually have pain, and most try to cope without using opiates or more complex medications. All NSAIDs, they create heart problems, anatomical heart problems to the babies. So we are not allowed to use them after the 20th week, 24th we say, but even before, we need to keep the doses low because of the heart problems. Ductus arteriosus is closing, and this might create pulmonary hypertension to babies, but also because it affects the kidneys. And we might end up with little amniotic fluid. So NSAIDs is a problem. I don't know what to suggest, because opiates, we don't want babies get hooked on them. So it's a big thing, but at least we don't need so much painkillers when we are pregnant, but most cases the diseases improve. And these are some of your, this is from the American College of Rheumatology guideline. You have the same here. We are allowed to use hydroxychloroquine, for example, sulfasalazine, colchicine, azathioprine is fine, prednisone, cyclosporin and tacrolimus are also okay. NSAIDs we talked about. Anti-TNF medications, they are okay, most of them. Okay, we are going to give them when we need to give them, lowest doses, and we can stop them at some point. We are not allowed to give these medications. These are teratogenic. So methotrexate, leflunomide, mycophenolate mofetil. Mycophenolate mofetil is also teratogenic for men. Men are actually quite lucky. There is very, very few medications like cyclophosphamide and mycophenolate mofetil that really affect their fertility and the fetus, the conceptus. But for women, it's different. Thalidomide is also no for men also. Thalidomide today is used both for RMDs, but also for leprosy. So this terrible teratogenic medication from 60, 70 years ago has given new indications and is used again. It's very effective. So it's the same thing we did before. And to finish this talk, safe and effective contraception to prevent unplanned pregnancy, pre-pregnancy counseling to encourage conception during periods of disease quiescence. We need the disease to be under control before we become pregnant. This is absolute. And while receiving pregnancy-compatible medications, so give time to change to other effective medications, and we need to have a multi-specialty team to take care of these patients. I read your and the rheumatologist, the guidelines. You look at it from that side of the picture. So you definitely need obstetricians and gynecologists in the picture, even though most of us don't answer correctly most of the times. But anyway, so I'm finished with this talk. I only have one slide because yesterday, Yesterday, earlier today, we spoke about HRT in rheumatic diseases. It is allowed. I leave it here. Again, we avoided for a specific. I leave it here just for people to see if they want to take a look, especially you that asked about it. So. Thank you so much, and I'm open for questions if I have time. I'm not sure how the time goes.
Okay, thank you very much, Mr. Elvi. Are you ready for any questions?
Thank you again for really interesting presentation. I have one question. You mentioned that biologics are not allowed to be taken after the second trimester.
No, I said they just cross the placenta.
Oh
Never
yes,
said
yes.
they're
You
not
said
allowed. Yes,
you said
okay.
that they cross the placenta. What about all the biologics? What about Cimzia? Cimzia, certolizumab.
Certolizumab.
Yes.
Actually, certolizumab is the one that doesn't cross the placenta because it's huge, and this we know it doesn't cross. So this one we might use as an alternative when we need to continue with biologicals during pregnancy.
Yeah.
So that's
Yeah.
that's an exception. I didn't mention because I didn't want to go too much in detail. Yes.
Yeah, that was.
Excellent. Thank you.
Again, thank you for the very interesting presentation. Again, for the biologicals, do you have any data about JAK inhibitors?
Well, JAK inhibitors seem to be, I don't remember if I have it here, but let's see. Maybe your colleagues have it. Oh no, it was in the other presentation of my colleague. I was saying JAK inhibitors are not contraindicated, but there's very, very limited data. Having limited data does not mean that we have a problem using things. And what we do in clinical teratology or reproductive toxicology is when we have no data or very limited case reports and et cetera, small series, what you do is you go back to the pharmacology. So how does the medication work? And what is the target? And then we go and look if the mechanism might have a plausible application in the developing organism that is the fetus. And sometimes even the pharmacology might give us an idea. Okay, sometimes you guess, sometimes you know. So many of these, as we call it, the tragedies in pharmacology, usually are prevented, can be prevented if you know pharmacology and use it, you apply it well. But the problem, what I was talking about earlier is, again in the workshop, we have a very big problem with the EMA as a society. They don't listen to us, and they prefer bowing to the pharmaceutical companies that they want to be safe. They put on their leaflets and on the authorization, market authorization of many medications not to be used, contraindicated for use, when the reality is that the reality is only limited data or no data available. So it's a different situation. Again, personalized approach, because I've said it many times, we need the mother alive in order to get the baby. And preferably, we need the mother alive also after the baby is born. So if you lose the mother, this is not good. Or if you kill the mother early, it's not good. Or if you deliver the baby early, it's not good.
And another one question, okay. Do you suggest to the patients with axial spondyloarthritis? With AxSpA ankylosing spondylitis, let's say.
Yes.
Okay, to deliver normally with the normal way or to make a cesarean?
I have no experience with that, but what would be the problem? Because of the pain or because
of the fusing of the back
if they
and
have
sacroiliac joints?
Look, if they have trouble to modulate, to move their spine, they might be unable to take the position to deliver. So in that case, yes, I would advise for, but it's an anatomical question mostly, or not anatomical, a physiotherapist question. No, I insist because 2 weeks ago, I delivered a baby in Thessaloniki. It was the second baby of one of my patients. She kind of became a little bit hysteric because she was afraid of pain. So she insisted on too much pain medication during the birth. So in the end, she was not able to push at all. So the baby came out. I kind of pulled a little bit, and the uterus brought it down. So in many cases, unless there is a very, very big, how do you say, the spine is really distorted, we are able to give birth.
Joints are fused, totally fused, and
Yeah,
the spine is totally fused. And then, okay, if it's normal, it's not possible, maybe because of the sacroiliac joints. But if you receive the opioids you put the injection in the spine. It's not
exactly.
possible. So how you do it? How you will do it in a patient
Not
with?
everybody delivers with epidural. So it is possible to do it without painkillers. I'm not advocating for normal birth here. I'm saying usually what happens in births, in obstetrics, is you do a trial. You see if it goes along. If it goes along, we try it. If it stops, if it hinders the delivery, you stop. I would be ready for any delivery to be stopped and convert. Usually that's what we are doing. But again, it depends on the level of distortion of the spine. And it depends of its body. Some bodies have more space. And also I want to tell you that we used to do it a lot many, many years ago, but now because we have the cesarean section, we don't do it anymore. We used to x-ray the pelvis. Some pelvises are really open. It's like a highway. Other pelvises of women, they are really, even in patients without ankylosing spondylitis. So it's a matter of what's happening, how it goes. But okay, if the patient is very stressed and they cannot think about it, or they read about it in online that, oh, terrible situation happened, I needed it. Okay, let's do the cesarean section. It doesn't matter.
One last question, please. I would like to ask you.
Yes.
How about IVF with aromatids? Is it possible? IVF? Are there any restrictions?
It is very safe, and we can go there, but it will be more complicated. We don't use prednisone at the time of how to say, in putting the embryo in, because it might, prednisone high doses might kill conception. Otherwise, there is no problem. But it's more complicated. Low molecular heparin or unfractionated heparin, extra medications, it's a bit more complicated. So I would advise anybody, okay, not practical and not socially acceptable anymore. Become pregnant before 30.
Thank you.
Yeah, thank you so much.